Right. Good evening. Good evening to you all. So we are meeting here to introduce how to take the Viva classes and history examination. So of course you have completed your MCQ recently, and you're waiting for the Viva. So there are students requesting me to upload this free class to the More Education, so they all can join to the class. So I don't think so, right? So at least we need to attend live classes sometime, right? So because all the class, even for the theory classes, also the paper class, a lot of students were joining through the More Education rather than the live class. So of course, so this More Education is helpful for your 24/7, but to recall your knowledge, but better to join to the live classes, right? So that would be better, and you can ask question. It is real time, right? So rather than joining or just watching like a movie. Of course, that is helpful, but whenever we conduct live class, you have to join to the live classes. Okay, perfect, right? So you might think why we are doing this free class. So actually, the purpose of doing free class, hopefully, I'm planning to introduce a person to you to speak something about the patient handling, right? So what we have done so far is we studied the theory, right? So we have studied the pathophysiology, we have studied the mechanism, we have studied the investigations, management, right? So we studied something in a theoretical background, right? So now you all are going to apply those theoretical stuff to the patients, right? So first time you are going to apply your knowledge to the patients, a human being, right? So actually speaking, these are kind of retrospective things, right? So earlier you were studying like postmenopausal bleeding will present, or endometrial CA will present with postmenopausal bleeding, right? So in Viva class, you are going to study in a retrospective manner like your SBA. So a woman presented with postmenopausal bleeding, what could be the reason? Because that particular patient will not tell you, doctor, I'm having endometrial cancer, can you treat me? But in MCQs, what has happened, they have given the real notes, right? So patient presented with postmenopausal bleeding and biopsy reveal endometrial cancer, and it's spread to the vagina. So what is the stage? How to manage? Now, you know the diagnosis, you can just manage the patient in Viva setup. But in clinical practice, actually, it is not the case. Now, the patient will come and tell you a symptom, a clue. So as a medical officer, as a consultant, as a doctor, as a house officer, your duty is to work out on that symptom. So if it is a postmenopausal bleeding, how are we going to investigate, or how are we going to evaluate that patient with postmenopausal bleeding? So it could be due to like atrophic endometritis or atrophic vaginitis, or it could be endometrial cancer, it could be a polyp, it could be a cervical cancer. So we are looking in the retrospective manner in a different way. So if you know the symptoms, what could be the real reason? So we are going to analyze the root, right? So then you need to find out the real reason for that particular patient, so particular symptom. So if you know that, obviously, then you can manage the patient rather than managing the symptom. So mostly, most of the doctors, what they do is they are just treating symptoms. Okay, they are just going, they just treat the particular symptoms. Like if it is a headache, just give paracetamol. Nausea, vomiting, just give domperidone. If it is dyspeptic symptom, like maybe a proton pump inhibitor or something like that. So symptomatic treatment, it is not acceptable in a good clinical practice, because without knowing the reason really, so patient is having back pain, fever, dysuria, nausea, vomiting, so it is maybe due to pyelonephritis. So first you need to identify what is the real reason for that nausea, vomiting, fever. So if you treat the pyelonephritis, obviously those symptoms will disappear. But if you treat like only the nausea, vomiting, or back pain, definitely the root will not treat. So as a clinician, what is your main concern is to find out the reason, right? So the first task in clinical exams or clinical practice is to find out the real reason. That is the first one. The second problem is, right, now in theory or maybe in your MCQ exams, what has happened is they were giving like, the important information. Oh, really sorry. I'll spotlight me, right. Right. So they were giving the real information, right? So the important informations are given by the examiners. So patient is like this, and this is the fourth pregnancy and second pregnancy, normal vaginal delivery, second, first pregnancy, this, that. So we are getting informations, but in clinical setup, no one is going to give the information. As a doctor, it's your duty to gather information, right? So here you are going to deal with the uneducated patients or medically not known patients. So they might not know what is parity, they might not know what is gravity, they might not know what is endometrial cancer. So those people don't know about the medical terminologies, they don't have any medical background knowledge. But you are a medical professional. A medical professional going to talk with the non-medical professional or non-medical people, or maybe uneducated, or maybe education level less than you, maybe education level better than you. So different kind of people are going to come to you. So you are going to discuss, or you are going to gather information from that particular patient, and you need to know what are the information you are going to take. With that big information, you are going to diagnose or maybe work out the management plan, then only you are going to treat. So the first task is you need to find out the real problem to manage. Second one is how you are going to gather information and how you are going to communicate from a patient or person who is medically not educated. Right. So when you are talking with the patient, actually, you can't just talk to the patient with some medical terminologies. Okay, when was your LRMP? So the patient might not know what is LRMP. So you may have to go to the patient's level. So different people are having different level of understanding. So if I am teaching to my level to you all can't understand. Right? Same time, if I am teaching to you like what I am doing for the postgraduate students, so I am teaching to the postgraduate students. So if I teach in that level to you, obviously you can't understand. Same time, I can't teach to the postgraduate students what I am doing for you. So because different people have different level of understanding. Even among you, few students might have very good knowledge, few students might have very fast understanding, few students might have very slow understanding. So different people might have different level of understanding. So what I'm going to do is I'm going to come to the level where the student can understand, then only I will explain. I can't use very difficult terminologies to you, but I don't want to go to this level for the postgraduate students. So likewise, when you talk to the patient will have different level of understanding, different level of educational knowledge, medical knowledge. So you need to identify up to which level you need to go to explain, up to which level you need to go to talk with them. So you can't stand somewhere and patient can't stand somewhere lower down. So then what will happen? Whatever the things you're asking, patient will not give the adequate information. So ultimately it will affect the patient as well as you. So in case of exam, if you are not gathering the proper information which you want to take really, then what will happen? Patient will not give if you are not asking in a proper way. So you should go to the patient level to gather information, right? So that is the most important part in information gathering. So second part in the information gathering is, right, so they are patients, right? So they have some problems, issues. They are not normal people. They are not normally or medically or mentally, they are not fit. They need some kind of sympathy, empathy. They need some kind of relief. So they came to you to get some relief, not only physical relief, not only treatment, also from the mental relief. So you are going to cure the disease. Curing the disease that doesn't mean you are just treating the disease. You are not just treating the disease. You are treating the disease. You are treating the patient's emotional stage. You are treating the patient's requirements, sometimes outside the medical career. Sometimes, say for example, if a patient, unmarried patient came to our ward to deliver the baby or mother, so we could deliver the baby and send her home. Yeah, of course, that is our duty. But beyond that, what we do, we are just looking what kind of help we can offer to her outside the pregnancy. Sometimes, so if it is unmarried or maybe a rape mother with pregnancy, so she can't look after the baby, she may have to give the baby for the adoption or something like that. So then what we do, we are just arranging someone, like, have you heard like Mitrupiyasa, GBV? So we are just communicate with those team to do the help for these patients. So you got the point. So not only treating the patient, also we are addressing the other issues as well. So what I'm trying to say is, right, so more than the disease, we may have to address their additional problem. We may have to respect their feelings. We may have to treat them in a respectful manner. You got the point, right? Also, a respectful manner. So those are the very important things, so which we are not doing. I will teach you how to behave like a good doctor, how to communicate with the patient, how to gather information, how to summarize the information, how to interpret the information, how to analyze the information, how to organize the information, how to summarize and present. Right? So as I told you, in theory class, the exam is an art. Exam is an art. Keep it in your mind. Exam is an art, right? So whatever the shit you know, it's not 100% going to help you, right? You might be very brilliant. You might be like a distinction marks person, but how you are going to present in the exam, it's going to determine you whether you are a good candidate, right? So once you complete this ERPM exam, you are going to be the house officer. You are going to be the doctor. What you are learning now, it's going to stay with you until you stop the practice, maybe until die, because doctors, we don't have retirement. So even after the government retirement, we are going to practice it. So if you learn the proper thing at the beginning, that will stay with you. That is what you are going to practice once you start your clinical practice, right? So whatever I'm going to train you here, it's going to stay with you for your all the time, right? So of course, you might not understand what I'm telling right now. Once you start your clinical practice, once you are working as a house officer, senior house officer, you will send me a message saying, sir, thank you very much to give that very good foundation. So that is what I'm getting the respect or response from the students, because how they are responding, because that is how I'm preparing. So especially for this ERPM Viva exam, it's kind of drama. So you need to perform to your examiner, right? So which need a series of training. You can just go and do in front of the examiner like the other subject, especially obs and gynae. It is very difficult, right? But if you understand the stuff, it's very easy, right? So if it is a medicine, pediatrics, surgery, you have long case, short case. You may have to perform long case examinations and presentation, short case examination and presentation. There are a lot of techniques to do the examination for each and every systems. But in obs and gynae, it's not like that. You have a patient, pregnant mother with symptoms or problems. You have an gynecology mother with problems. Your aim is to identify the problem, discuss the management with the examiner. So it's totally different. So how we are going to prepare it, right? The way we are preparing is very, very successful method, because we have a witness. We all know that, right? So far, the Genops pass rate up to last year, it was 30%, right? So I'm doing these classes for more than 4 years, but unfortunately, I was not popular among the students due to several reasons. But because of this online classes, people got to know me. Then last time, you all know, the Genops is the highest pass rate subject. Overall pass rate was 75% than the other subjects. But in the history, it was 30. The first time it has been increased to 75%. Overall pass rate 75% from 30%. So you could imagine how we could achieve that. Is it because of me? Obviously, no. What I have done, I didn't do anything. What I have done, I just told the correct way to my students. So this is the correct way you have to do. This is the correct way you have to practice in exam. So we did the series of practice sessions. So ultimately, the output is the highest, the first place. The highest pass rate in ERPM subject was Genops. 75%. 75%. And out of 75%, my students who came to my class, they contribute like more than 90% pass rate. So rest of the students who never attend to my class, they had only 30% pass rate. So when it is calculating together, it was 75. So another thing is, when you are coming to the hospitals now some students are working under me as a house officer, my students, some senior house officers. So now you could realize, when you are working as a house officer, you could realize how important we are studying. What is the way we are studying? So the purpose of doing this free class, I will tell you. Before I will tell you how our Viva class is going to. So we will discuss the important cases, or not the case, the subjects related to obstetrics and gynecology in 14 classes. First 7 class will be session 1, and first, second 7 classes will be session 2. Then the third one is emergency session. So in session 1, session 2, I'm going to explain you how to take the history, what are the relevant thing in obstetrics, what are the relevant thing in gynecology to the particular things, and how to do the examinations, right? So information gathering, so kind of background knowledge. So then in the emergency part, we will discuss how to answer the emergency Viva, and I'll explain you how to some instruments and all, right? So you can see the instruments. Those things will be done in emergency part. In addition to that, so I will do series of free events for you, right? As we did in last time. So the first one is the case discussion. So that was the main reason for my success in last time, right? So after finishing this, we have done like last time we have done like 14 or 15 free case discussions. So those case discussions are only for the students who attend to my classes, stage 1 and stage 2. So what we do, I used to bring the patient to the class, right? So you can, one of you can take the history. I will guide you how to take history, where you are doing mistakes, how to approach to that particular patient, how you are deviating from the real case. So where you are missing the information. So how to improve that, right? Along with that, I will explain you. So we have through the video, I will explain every examination. So this is one case discussion. But of course, why we are doing the case discussion through the Zoom? Because when we are doing the case discussion, like if it is 200, 300 students, rest of the students are going to be witness for that. So when one person is taking the history, rest of the people know how to take the history, how we are missing, right? So then you will not do that. So randomly, or maybe I usually ask the students who are really willing to take the history, so then I will guide them. So in addition to that, we did last time the small group discussion. So because some students might not willing to present or take history in front of everyone. Yeah, that's acceptable, right? So, but at least once, a single student, at least one, a student, he or she has to present the history to me. I need to correct you because it is a practical one, right? So I need to correct you, whether you are doing good, whether you are presenting good, whether you are organizing good. So the students who are really having difficulties to present in front of everyone, we do a small group discussion. Before you go for an exam, I will make sure, yes, you are eligible to go to the exam. If you are a bit of, if you want more practice, so then I will do more case discussion with you. Those students who really want those, because ultimate target is, as than you, I have to maintain my pass rate. So for last 4 years, I'm having more than 90% pass rate. But number of students was a bit low earlier. After the online, I have a huge number of students, but still I could maintain the pass rate. Even when 412 students attend to my class, I could maintain more than 90% pass, around 95% pass rate. It means whatever the number comes. So if you come to my class, more than 95%, you will pass. So then what is the reason for that 5% failure rate? I can tell you the reason. Wait. So there could be, there are reasons. Still, even though you are practicing in a proper way, still you can fail the exam. So you should know your strength, weakness, opportunities, threats, right? So then only you can prepare yourself very well. So have you heard SWOT analysis? So I will teach you in that way, right? Have you heard SWOT analysis? So you need to do your SWOT analysis. Then only you can pass the exam, right? So, so what we are going to do is, as I told you, session 1, session 2, session 3, then case discussion and small group discussion. In addition to that, those examination videos I will show you through the Zooms. You can see that is third one. Next one. Next to that, I will arrange free clinical visits to the hospitals with the permission, right? Because as we all know, we have some issues to get the pregnant mothers outside easily because of this COVID and all. And most of the examinations, what we are doing is very sensitive, like vaginal examination, speculum examination, right? So by you are giving the money like 2,000 or 3,000 for your case discussion, a woman will not happy to show their vagina for the money. You will agree that? So it is not possible as the other subjects. So it is, so we can, or otherwise if you really want, I can do with the models. So but I don't believe that doing the model, you have to do the examinations in a real patient. So doing a paid session outside might be difficult. So I can arrange a paid session outside with the models, but I usually not prefer. But if you guys really want the examination on models, yes, I can do that, right? So instead of that, what I am doing is I am doing a clinical sessions in hospitals with the real patient, right? So last time I have done clinical session in Mullaitivu as well as in Colombo. Mullaitivu around 250 students came, and Colombo around 150 students came to Kalabovila Hospital. But what is the difference is, in Mullaitivu I have taught to them, right? I was the instructor. In Colombo, I arranged someone to do the class, right? But anyhow, the students who couldn't come to the Mullaitivu, I arranged the classes in Colombo last time. This is how I did in last time. This time, I'm planning to do sessions in base hospital Telepala, where I am working as a VOG, and probably one hospital in Colombo, maybe in a limited time. That one also I plan to do myself. We'll see with the time, right? But those are going to be a free session. We are not going to charge any amount, because by getting charged for your practicals, we can't give money to show their vagina. We can't insult a woman. But when you come to the hospital as a medical student, that is the responsibility of the patient also to give a chance to learn. That is acceptable. So this time also I'm going to continue that. So the plan is the clinical session will be like 3 days per group. You can stay maximum 3 days with me. So you can join with me with the ward rounds, clinics, right? And I will teach you how to take the history, how to present the history, how to do the examination, abdomen examination, vaginal examination, speculum examination, and all, right? So those are completely free of charge. You may have to come and stay in Telepale. Yeah, we have the accommodation arrangement and all. You can come like a group of people, but maximum 15 to 20 students per group, because I don't believe if more students are coming, whether it will be useful for you, right? So right, so I will allow like 25 to 20, 15 to 20 students per group. So the first group will start on this 27th. So students who join to session 1, stage 1 and stage 2 Viva class are eligible to join to my hospital classes, right? So you may have to take the permission. With the proper permission, I will arrange those kind of things. You can learn, because you are going to be our next generation of doctors. So you need to learn. And one more advice is, if you can come a bit early, that would be better for you, because you all know there are issues are going, because some of you, not all, some students did the hospital attachment with some other hospital, something like, and they got some letters saying I did the observation job or observation in this ward, like that, and they were trying to submit as an internship for their SLMC eligibility. So due to those events, now there was some discussion to stop this kind of hospital attachment by for the foreign students. So because of someone's mistake, everybody is going to affect, right? So what I'm trying to say is, when we are starting, this kind of problem also might come. So if those problem comes, obviously the rest of the students might not able to participate the live examination discussions. So then I will do the model one, right? So what I'm trying to say is, whoever wanted to join, please utilize the initial time slots rather than going to the late time slots, because I'm not sure about the later part. So you need to understand, this is what I told you, SWOT analysis. You need to know your strength, weakness, opportunities, and threat. This is the threat. So if you know this, then you can plan out things. You don't need to worry without knowing these things. How can we attend to the class? Because I am the teacher going to explain you. Even if a nursery student come, I can explain in a proper way. So you don't need to worry about that, right? You don't need to know each and everything to come to the clinicals. So I will explain you how to examine, how to approach to the patient and all, right? So I will send the SMS through the information through the Viva group. So those who are joining to the class, I will send the message. So when is the first slot, when is the second slot, when is the third slot? So once you pay, you will be in the group. So then I can discuss those things through that group. So that is a closed group. So you all have to book that slots. So whoever book first, you will get the chance. And if somebody books, if you are canceling your slot, so please tell us a bit early to arrange someone. If you waste your time, obviously it will affect someone opportunity as well. So you won't get another chance again, right? So again, I'm telling, it is a free of charge. You don't need to pay, right? So if you want any information, you can contact me later, right? Okay. So this is the summary. So we are going to start with this session 27th, and we are going to work for another 2 or 2.5 months. So at the end of 2.5 months, you should be ready to pass the exam. So that is my responsibility. Once you come to my class, that is my responsibility to make you pass. So I will take that responsibility. I will teach you the way you can pass. Okay, right. So then suddenly you might think why I wanted to do this free class. Actually, I was planning to do a series of free class for all students, for everyone, whether who are coming to my class or not. But those free classes will not be available in recordings, because I know you people might think it will be available, but it is going to be like, because talking to the patient, communication, it's kind of very difficult these days. One of the reason is, now the newer generation, they are mainly confined to the telephone, mobile phone, right? It's not like the previous. So people don't know how to communicate in a proper way, right? So that is the main reason for your failures. You don't know how to talk to the patient. You don't know how to handle the patient who is in angry mood. You don't know how to talk to the patient who is crying. Those are the very, very problematic thing. Second one, explaining breaking the bad news. So if it is an intrauterine fetal death, a mother who is having baby first time and with the lot of expectation, right? She came to the hospital. You have done a scan. There were no heartbeat. You want to tell your baby has died. So how to break the bad news? So you can't just tell like the other subjects or other symptoms, like You have this, you can do. So you can't tell because you don't feel it, how difficult it is. Right? So you have to think when you're breaking the bad news, how it affects the patient's mentality. So there are ways to breaking the bad news. Another example or another problem, when you're explaining some problems, or when you're disclosing some problems or some investigations, we are not concerning about their mentality and their social factors, right? So commonly we are seeing, say for example, if it is a subfertile couple, when they are coming for the treatment, the husband might have azoospermia, or wife might have premature ovarian failure or bilateral tubal blockage. So how we are going to tell that your husband is having azoospermia, your wife is having bilateral tubal block, right? So how we are going to tell that? Because we have seen when my house officers or maybe a senior house officers, when they are explaining or exposing that, disclosing that news, Amma, your husband is having a problem with the sperm, he does not have sperm, so that is the reason for the subfertility. That's it, right? What they have done is correct. What they have told is correct. The fact is correct. Because husband is azoospermic, because of the azoospermia, they are subfertile. There is no question. Right? That fact is correct. But with that words only, in addition to the subfertility, there are so many problems are arising in that family. Now, they both were fighting for the baby. They were both were trying for a baby. Now, what you have done is you have pointed that problem towards one person. Right? So then what is happening now? The wife is going to start like, see, you were telling about me, you asking like this. No, you have the problem. You are the reason for mine. That's why I'm crying. Now people are asking, where is the baby? Now what can I tell? Now the fight is starting with the husband and wife, mother-in-law and daughter-in-law or son-in-law. So now you made a storm in their family. So this is happening commonly because we don't know how to tell those things. There are ways to tell. So sometimes one incident, I got a patient, like subfertile patient. They got married and trying for a baby for 3 years. So very good, very beautiful girl, very beautiful girl. She came to the hospital. So when we are examining, her breast is very well developed and she's very well feminized and very beautiful, short vagina. And also she's having amenorrhea. So short vagina, well developed secondary sexual characteristic, amenorrhea. So could be a Mullerian agenesis or androgen insensitivity syndrome. So we did karyotyping. So karyotyping came as XY. So XY means it's a male karyotyping pattern with androgen insensitivity syndrome. Now, that beautiful girl is genotypically male. It's a very beautiful girl, but she's male actually. Now, what are you going to tell? Are you going to tell to that girl, you are not a girl, you are a male? Are you going to tell to the husband, you marry a male? You are trying for a baby with a male. You are doing the sexual intercourse with the male for last 3 years. How to tell that? How I am going to disclose this one to the patient? Right? So this is not like other subjects, especially obscene. It's very sensitive. Right? Very sensitive. They are going to share with you like their sexual problems, something they can't discuss with anyone. They're going to tell you. Right? So it's very sensitive. So when they are talking in a sensitive manner, you have to respond according to that, when a patient is telling, like, doctor, my husband is not having interest towards me, and he has some problem with erection and ejaculation, and he's not doing anything. Even I try, but he is not interested. When she's telling something very sensitive to you, that time your body language, your response, your expression are very important. When the patient is telling these kind of things, then you ask, then, so that you can't show you kind of interest on that. You got the point? So it is for you, it's like a fever, headache, nausea, vomiting. But you have to have a good body language, your expression. So non-verbal communication, you got the point. Non-verbal communication play a major role in obs-and-gynae, right? So then only people will tell you you are a good doctor. So if you go to UK, if you are going to do MRCOG, obviously the non-verbal communication play a major role in your marks, right? How you are responding, respecting the patient more than the words. So the aim of teaching here is not only giving the knowledge, also to develop your non-verbal communication, develop your verbal communication, counseling ability. You got the point? So everything. So then only you will be a good doctor. So once we start the course, once we are doing the case discussion, that is the most important thing, case discussion. So then I will teach you. Obviously, doing case discussion and kind of things are very difficult with me, because once I start to train you, then you will get to know, right? So I will bite you that much, because then only you will get to know how much you want to know. But the end results is pass. So we need that end results, right? So now the new generation of doctors, sadly, they are very weak on this counseling, breaking bad news, non-verbal communication, approaching to the patient. As an exam candidate, you have problem with approaching to the examiners as well. So that's why I decided to do a free session on this aspect. So the theory, right? So theory part, the related theory knowledge, examination technique, case discussion, case presentation, obviously we can do during our course. But who is going to teach you these non-verbal things? So I thought to take that responsibility. So that is what I was thinking. So I really wanted to give this knowledge with the help of some specialty people on this, right? So recently, the last week, I had a chance to meet a person called Father Damien, right? He was the teacher to me. He's very, very older, very experienced. He's a lecturer in psychology, not psychiatry. He's a lecturer in psychology, senior counselor, and also he's a lecturer in Jaffna Medical Faculty, lecturer in Jaffna University, and also he's a lecturer in theology department, Rome, right? So he's a kind of internationally recognized person. So I used to meet him, and also I used to have a chat with him, and I learned a lot of things. Still, I'm having good contact with him, and he also liked to meet me frequently. So then last week I had a chance to meet him. So then that time I was discussing with Father Damien regarding this. Then he said, I'm really interested. Thank you, doctor. You are thinking in a wise manner. So I'm really interested to guide my next generation doctors regarding this aspect. So he would like to do the series of lectures to you regarding the patient's approach and breaking bad news, right? And non-verbal communication and all. So I think that would be better one. And also I'm going to share those links not only to the students, also to the doctors who are currently working. So probably that will be a big free session, I'm thinking, because this is a very important topic for the medical practitioners, right? So I thought to introduce him today, but unfortunately now I invite him to participate in this meeting at 7 a.m., 7 p.m. So I thought to do the introduction until 7 p.m. and by 7 p.m. But he now messaged me. There is a power cut in his area, so he couldn't join to the meeting. So that is a problem, right? So I said, okay, so we will do next time. So I'm planning to continue this free session for that. So I will really want this one. No, what is your feedback? Do you really want this one? If not, no problem. I will not share this link to you. I will share this links to this doctors who are working and postgraduate students. Right? So I think that is very important for your exam as well, right? So we'll see. So really, I'm very sorry. Yeah, he texted. We'll see what he was telling. Thanks. Sorry for the input. Okay. Yeah. Anyhow, he can't join today because of the power cut. So probably he will join to the next class, right? So the purpose of this free class series is that because I want to give you the non-verbal communication, right? So then at least when you are going to do the clinical practice, you will be a good doctor, right? So that is kind of different topics. This is not a subject. This is psychology, right? So, and non-verbal communication. This is not purely depend the medicine. This is something else. So it's psychology department attached to non-medical faculties, right? So yeah, I'll try to continue this one as a free session. So you all can maximally utilize him, right? So I also will join with him and I can share some experiences and patient examples, how they would present, and we can do some model discussions, something like that. So how to disclose those things and all, right? So we may have to start maybe once in a week or once in 2 weeks with the Father Damien's free time. So he's a Catholic priest, right? So Father Damien. So I will contact him again and I will try to arrange this one in future. Okay, right. That's perfect. Now I'm going to explain you or teaching you how we are going to do the history taking examination in obstetrics and gynecology. So that is our main concern, right? So obviously, in stage 1, the one class is going to be how to take the history, and second class is going to be how to take the obstetric history. But anyhow, today I'm going to teach you how to take history in medical setup, right? So as we all know, history taking, it's an art, right? History taking is an art. So can I have a volunteer to take a history? Anyone? If any volunteer, yes, of course, we can discuss like a role play. If not, I will do like theory. What you want, like a role play, practical manner, or a theory manner. Anyone? Shall I? Yes, of course. Whoever, no problem. So don't worry. So the first thing, especially in Viva classes, so don't feel shy, right? So whenever, because this is not like your MCQ. You are not going to, we are not going to do with the papers, right? So you are going to present to the human being. So you need practice. Don't think I will present very well to the examiner. When you're trying to present first time in front of the examiner, then it will be the worst thing in your life. So you need more practice. So I will teach you when you are coming to the Viva class. I used to tell the students to present to themselves in front of mirror. I used to tell them to record their presentation and listen again. When you record and listen, that time only you will realize how horrible your history presentation. Otherwise, you don't understand what you are doing. You might think I'm performing very well, but whenever you listen, because I felt that when I'm seeing my own videos after the Zoom class, only I realize, oh, how horrible I am teaching. So the next class, I'm modifying myself. You got the point. Otherwise, I don't see the response, right? So how students are responding, so if I am a student, how can I interpret that? So then when you record your presentation, you can see, right, how the examiner will interpret it. So this is the practice. So if anybody willing, I can do a role play. If not, I'll start. Anybody? Yeah, somebody asked, shall I? Yes. Hello.
Sir, I will take this too.
Okay, perfect. Thank you for your volunteer work. Really appreciate it. Yes. Okay, I'm a woman. I came to the gynecological needs. Just take the history, whatever.
It's in English or Sinhala?
Yes, English.
මේ අම්මා මම අවසාන වසරේ වෛද්‍ය ශිෂ්‍යයෙක්. මම මේ එක්සෑම් එකට ඇවිත් ඉන්නේ. මේ ප්‍රශ්නය කිප දෙනෙක් අහුවන කමක් නැද්ද?
Okay, කමක් නැහැ ડોක්ටර්.
අම්මගේ නම මොකද්ද?
සංජීවනි.
වයස?
43 years.
43 years old. From where are you coming?
From Colombo, Dehiwala.
Dehiwala. Are you married?
Yeah, of course. I have 3 kids, doctor.
3 kids.
Yeah.
3 kids means how the mode, what is the delivery mode? Normal the cesarean the Kundanama?
All normal, doctor.
Normal.
Oh.
Then what is the reason Amma came to the hospital?
Doctor, I'm having bleeding.
Bleeding.
Oh.
For how long?
Like 4-5 years I'm having bleeding.
Mm-hmm. 5 years.
You know, doctor, now I'm working in No Limit. So I used to go to the work. Now 4-5 years I'm suffering because of this bleeding, and my husband also fighting with me because I'm not earning and my kids are not listening me, and sometimes I can't cook, and I always sleeping, and you know, even my mother-in-law last time she came from Candy, so she was shouting at me, and you know, yesterday also we had a problem with I had a problem with my husband and mother-in-law. It is very, very difficult, you know. Like that, when I was working in No Limit also, one of my friend also told like that she has the same with the mother-in-law, and I don't know, it's all the women are getting this kind of problem. No, why I born like a female and having bleeding like this, doctor? So can't you have a solution for this, doctor? Why it is?
Yeah, is it bleeding at the
vagina, bleeding at the vagina?
Vagina, is it bleeding continuously or you are having bleeding while menstruating?
What you ask, doctor? I don't understand. I don't know what is the difference between bleeding and menstruation. I'm having bleeding.
Other than the menstruation, are you bleeding
How,
or
how to identify the menstruation, doctor?
identification?
How to identify the menstruation, doctor?
Every month period I mean that
Yeah. Every month is I have bleeding. It is very excessive, doctor. I'm having heavy bleeding. That's what I'm
heavy
telling.
other than the heavy period time, are you bleeding?
No.
No, you're not bleeding. So it's like heavy.
Oh, yes.
So are you passing like clots or something?
Yes.
Okay. So how long it takes the bleeding?
Like
How many days? It will be
most of the days, doctor, I'm having bleeding. So I'm having bleeding. Maybe it might stop, and after 5-6 days again, I'm having bleeding. So I don't know what to do.
Mhm. So how
Okay,
many patties?
we will come to the rest of the history bit later. Now, here, yeah, thank you, but we will join bit later. Now I am going to explain you what was the real problem and uh, how to tackle this. So I just want to explain you what is the real problem during the history taking. Okay, right now. Thank you. Thanks a lot. Now you can see, give me. Right. So here, what I was noticing is, right. So not only you, also the students who were helping in the chat, right. So everybody is concentrating what to ask next. Lethargy, hemoglobin amount, everyday bleeding, clots, abdominal pain. So now this is what we do mistakes, right? So I'm not going to teach you. I will teach you what are the relevant things you need to ask from the patient, right? But now, what are the real problem with this patient other than this bleeding? Now the patient is very talkative, right? Patient is telling some other story. So then how you are going to interrupt that one? So when the patient is telling something and patient is telling my mother-in-law is doing, father-in-law is doing, and one of my friend also doing this and blah 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 things. So when the patient is very talkative, somewhere you have to interrupt and you need to continue your information gathering. But when you are interrupting the patient, that should not affect the patient mentality. So when the patient is telling some story, when you are just interrupted, then patient might think this doctor is not listening what I'm telling. This doctor is not understanding what is the important thing. So you have to interrupt in a way without giving some bad experience or bad interpretation to the patient, right? So the second thing is, when you are discussing or when you're asking something, we should clear what I'm going to ask, right? So when we can't use the terminologies, some medical terminologies, we can't just ask, okay, What do you think? What do you think? Is it different from menstrual bleeding or other bleeding? So I know what you were asking is, you wanted to ask whether she has intermenstrual bleeding, whether she's having menstrual bleeding or bleeding in between the cycle. So to ask that, you can't ask, oh, what about the period, and it is different from the period, then patient will not understand. So you can ask in a different way. So here the communication is the most important part. The communication. So just listen one or two things at the beginning, and you have to plan out what you are going to ask. Right? So you can't talk to the patient unnecessarily. When the patient is talking unnecessarily, you need to know how to convert that conversation to the point where you want to ask the question. Right? So there are several ways, because these are communication, several ways to interpret that. So you could simply ask, okay, Amma, right? So when was the last baby delivered? When was the LRMP? How many days it was lasting? So before that, how was the period? So whether usually she's getting period in this frequency. So you said you had a period in last 20th. Before that, you said in November 20th. So in between November 20th and December 20th, have you had bleeding? So then patient can understand what you are trying to ask is. You got the point. So sometimes depend on the patient educational level. So if it is a doctor came with heavy bleeding, then straight away you can ask, okay, when was the LRMB? How is your period? Is it regular, irregular? So you can use those terminologies. You can ask in that way for a patient, if a patient is a doctor or maybe a nursing officer. But if the patient is a normal person who is really don't have a medical knowledge, so then we need to go to their level. You need to go to their level, right? So I will teach you, when you are taking the history, when the patient is very talkative, how to handle this one. It's simple way. What you have to do is, initially we ask 2 or 3 open questions. Right? Initially, we ask 2 or 3 open questions. Those open questions will tell us whether you need to ask further, or you can plan out your history with the closed question. So before I explain you what is open question and closed question, so just wanted to summarize you. Now, when the patient is coming to you, first, you need to understand, or you need to identify what is the real problem which brought her to the hospital, and what is the real symptoms might lead you to the diagnosis. These are the 2 things. Right? Patient might have heavy bleeding. So she's having bleeding for 5 years. Right? But she came to the hospital right now. Why she didn't come for 5 years? Why she came right now? So few symptoms might brought her to the hospital now, but she might have some problem for a long period that would help you to take you to the diagnosis. She might come to the hospital because of the nausea, vomiting, giddiness, anemic symptoms. But anemia will not bring you to the diagnosis. Anemia is the symptom you have to treat, and that is the symptom which brought her to the hospital. But the diagnosis can be done with the regular heavy menstrual bleeding for 5 years. That is the symptom will bring you to the diagnosis, not the anemia symptoms. So you have to differentiate these 2 symptoms. So don't worry, this is the first class. I'm just making you to understand how to approach to the patient. So throughout our course, what we are going to do, I'm going to teach you how to identify these things. In the case discussion, I will teach you how to approach to the patient to get this information. So with the initial conversation, our aim is to identify why she came to the hospital. That symptom is brought her to the hospital. But that might not help you to diagnose. So you need to find out what is the symptom will help you to diagnose the condition. So you can't restrict the patient at beginning. So when I'm starting to teach you, now I came to teach you the free class, I want to tell you how to approach the patient, how to approach the examiner, how to identify the problem. When I'm trying to teach you all these aspects, right? If Mayuri asks like, sir, how to identify the presenting complaint? So then what Mayuri is doing at the beginning, she's trying to restrict me. So thereafter, you can't detect rest of the problem. So rest of the things. So you are not supposed to restrict the patient at beginning. You need to let the patient to talk outside openly. So here we can use two kind of thing. One is open question. In the open question, I am not restricting the patient. I am letting the patient to talk openly. Then patient might tell a lot of things. Patient might tell, I'm going to no limit. I'm working in no limit. My grandma is fighting with me. My husband is fighting. One of my friends also had same problem. She's telling a lot of things. But as a clinician, you should know which one is important for you. So with the open question, you can identify what could be the real problem she might have. What symptom you need to further evaluate. What are the problems you need to evaluate to that particular patient. So those open questions will help you to plan out your history taking and evaluation. Right? So always you need to ask the open question at the beginning. With the open question, we have some idea. Yes, this patient is having following problem. These are the symptoms I need to evaluate. So then what we do for that, then I'm not going to allow the patient all the time, because in clinical setup or in exam setup, you have limited time. You have limited time in the exam. Just total history taking examination and discussion is just 20 minutes. Even though they said 10 minutes for the history taking and examination, sometimes some examiners are not allowing you to take the history more than 10 minutes or more than 5 minutes. They just ask to take quick, take the history, present the summary, come. So they are telling like that. You got the point? So you have a limited time. So if you let the patient to talk for a long time, every time patient, if you let the patient to talk in an open way, patient always talking in an open way, talking. So ultimately what will happen? You can't identify the real problem within that short period. When you are working as a house officer, or when you are working as a senior house officer, medical officer, register, senior register, consultant. So for example, if I am as a consultant, when I'm consultating outside, when I'm seeing the patient, I can spend like 5 to 10 minutes per patient. So within that 5 to 10 minutes, 10 minutes, I need to take history, examination, ultrasound scan, and prescribe the drug and explain the disease and explain how to use the drug and what are the possibilities. Just imagine how it is possible to do within that 10 minutes. Very targeted history taking and assessment. That is what I'm going to train you. How to take targeted history taking. So you need to identify the problem very quickly, analyze that symptoms and plan out your management within a short period. You got the point? Even the exam also, you will have the same problem. Within short period, you need to analyze the symptom. So this is an art, not like your MCQ theory. By listening, by watching, you can't quickly learn this one. It is an art. You have to practice. You need time. So that's why I wanted to start the clinicals and case discussion a bit early. While we are doing these classes with an extra time, maybe in the night time, 9 o'clock, 9:30, I will do the case discussion. So you all have to join to the case discussion. So the previous batch I did around 14 case discussion. Those videos will be available in Maura. You can watch those case discussion. So this time we will do fresh live case discussion. So with the live case discussion, you will get more exposure. So ultimately you might get 30 case discussion, maybe like do many case discussion as you can. Of course, that's what I'm going to do. That will help you to pass the exam. Right? So now the open questions will help you to plan out. Then the closed discussion with closed questions. Those closed questions will limit the time, will help you to gather targeted information. In the closed discussion or closed question, usually I'm not allowing the patient to talk much. I am taking the responsibility. I am taking the role. So always the ball should be with you, right? So if you give the ball to the examiner, if you give the ball to the patient, then always they are shooting. Then you are just observer. So when you are taking the second part in closed question, you need to ask the targeted questions. Okay. So do you pass clots? Do you have pain? Is pain start with period? Is it lasting after the period? Here, you are letting the patient to say yes or no. You are just letting the patient to say yes or no. Do you have pain? What is the answer? Yes or no. Right? But if you want to ask the closed question, now you need to know what are the relevant symptoms you need to know for this patient. That's why I told you at the beginning with the open question, we are having some idea what is the real problem. So now this patient is having regular heavy menstrual bleeding with pain or without pain, we don't know. So if it is a regular heavy menstrual bleeding, it could be a fibroid. It could be adenomyosis. It could be endometriosis. It could be pelvic inflammatory disease. It could be hyperplasia or malignancy. So to differentiate these things, you may have to ask some additional questions. So regular heavy menstrual bleeding, is it associated with pain? If it is associated with pain, it could be adenomyosis. It could be PID. It could be endometriosis. So you are cutting down your possibility into half with that word. But if you let the patient to say whether she is having pain or not, she might say she's having pain, so she might not say she is having pain. But to get to know that, you have to wait for 2 to 3 minutes. She will tell rest of the stories as well. But those stories are not relevant to you. So while she is talking in that way, you can't just stop. Amma, please tell me this question. You can't ask like that. So what you have, so after the open question, you have to take the part. So then just ask some question which you want to know. Do you have pain? Do you have pervaginal discharge? Do you have back pain? So only with the closed question, you are restricting the patient to say yes or no. Right? So we have two type of question. One is open question. Second one is closed question. So always we ask open question at beginning, plan out your management or your evaluation, then use your background knowledge to ask the closed question. Okay, with me? We just ask the closed question. We are not letting the patient to talk much. Right? So now the second problem, most of the students are misinterpreting. Okay. What are the possible, What are the cases usually you are getting in obstetrics? Yeah, Rismi, can you just tell me what are the cases you can get it in obstetrics? Anyone? What are the cases?
RH immunization,
RH immunization, okay.
diabetes in pregnancy, hypertension in pregnancy,
Diabetes in pregnancy,
hypertension pregnancy.
hypertension, IUGR. Yeah, agree? Yes. So you might get diabetes. Another one might get hypertension. Another one might get
Anemia.
anemia. Another one might get LSCS, pars section. So in obstetrics or gynecology, so can you just tell me some gynecology cases?
Heavy menstrual bleeding.
Okay, heavy menstrual bleeding.
5. PID.
Pelvic inflammatory disease, subfertility, pelvic
Ovarian cyst,
ovarian neoplasm, ovarian cancer,
cervical CA, endometrial
cervical
CA.
cancer, whatever. Yeah, okay. So you might get cases in gynae, you might get cases in obs. So how to predict what kind of case you can get it? Whether it's a GDM case or PIH case, how to predict?
It's depend on the station, sir. We can predict.
Yeah, Lasanda? Depend on the pregnancy. Welcome, Yasanda. Okay. How to predict? Right. So this is what the second take-home message is. You won't get any cases in your gynae obs. Right. So don't go to the exam with the expectations of cases. You will not get any cases. You will get a pregnant mother or you will get a woman. That's only. You won't get any cases. But that pregnant mother might have some problem or might not have any problem. Can you have uncomplicated pregnancy for your exam?
Yes.
Yes, of course. So if you go with an idea, some cases, GDM, PIH, IUGR, when you are taking the history, until 10 minutes, even you don't identify what is the case it is. So then what you are going to present then? Then what you are going to present then? So the most important message is you will not get any cases. Okay? Keep it in your mind. You will not get any cases in obstetrics or gynecology. You will get a pregnant mother, you will get a woman, or maybe a couple. So what is your aim with that pregnant mother? What is your aim with that pregnant mother?
Identify problems, sir.
Very good. Identify the problem. She might have problem or problems. That patient might have GDM, that patient might have PIH, that patient might have previous section. Now baby is complicated with IUGR. So when that mother has PIH, IUGR with pars section, what is the case you are going to present now? PIH case, pars section case, or IUGR case? Which one you are going to present now?
All.
So then how can you say, I got PIH, I got IUGR case, I got pars section case? So you are practicing. This is the reason you had 30% pass rate earlier, right? So they just divide 6 class, anti-obs and gynae. Today PIH case, GDM case, and IUGR case. So training the students to take that particular case, give a format, make them to memorize. So they are memorizing, which is a PIH, LRMB, PIH management. So they are trying to memorize certain question for that particular case. Then they are just going to the patient and asking, Amma, what's the problem? Do you have any problem? PIH, okay, PIH, okay, this is a PIH case, and they are asking, they memorize something and they try to ask that particular question to that case, and they are coming out. But she might have IUGR, she might have parasitic, she might have anemia. So who is going to take that history? How you can take entire each and every separate history here? PIH case finished now. Anemia case finished now. IUGR case finished. Now how you are going to combine all these cases? How you are going to present? So what you are going to present? PIH case or IUGR case or anemia case or pars section case? Which one you are going to present now? Now you all know why your seniors failed a lot. Because don't go behind the case. Don't go behind the case. There is no cases. There is a pregnant mother with problems. So your aim is to find the problems. So you can identify a hell lot of problems with an open question. Then you can fine tune with your closed questions. Right? So my way of preparation is going to be like this. I'm not going to teach you, these are the standard question, these are the cases, question for the observation. So I will give you the notes. That is different issue. I will give you the notes for the PIH means what are the questions you need to ask in English format, Tamil format, Sinhala format. I will give you the history related to that. But when I'm training you, I will teach you how to combine all these things and identify the problem and how to present in a combined manner. Because you are not going to treat the Malkanti, not the PIH. Are you going to treat the PIH or are you going to treat the pregnant mother? Pregnant mother. So you have to see as patient, not as case. This is the most important thing. You might not, and I don't know whether you understood what I'm trying to say, but when you start to do the classes, case discussion, when you go to the exam, when you go to the clinical practice, you will realize it. So honestly, I'm really very proud when my students are presenting to the exam. So I have all the screenshot what the examiners was telling for my students. Right? So they were asking, which university? Where did you study? You're awesome. Because the way they were talking, way they were analyzing, way they were identifying the problem. So that is the only thing I want from you. So when the examiner is looking at you, now you are going to perform in front of someone. So that is going to reflect me, not you. If you do well, of course, your talent, but definitely they will ask, where did you study this? So you are going to reflect me in front of others. So I will train you how to identify the problem and how to analyze the problem, how to present in a concise manner, how to organize, summarize and present all these problems within that 2 to 3 minutes. That's why I am telling it is an art. It needs practice. We need time to get practice. It's not an MCQ. So you need to do practice, more and more practice. Even if you do 100 case discussion, still not enough. So the postgraduate students are coming in the midnight for the case presentation because they need more. So they are senior, they are registers for 3 years. They are going to be the senior registrar. They expose several cases. So in the board for a long time, but still they want to present. Why? Because every time, every patients are different. It could be GDM. Of course, I agree. Rizmi might get GDM, Mayuri might get GDM, Maushida might get GDM, Sajan might get GDM. All four might get GDM, but all 4 GDMs are same, not same. Because patient age might different, parity might different. So when it is differing from parity or age, 28-year-old GDM and 40-year-old GDM, your management is totally different. Your assessment is totally different. Of course, all are GDM. If you go behind the case, then you might miss the important thing. You might miss the pregnancy. You might miss the good pregnancy outcome. It might end up in IUD. So it's a tailor-made management. So the students who are coming to my ward, Lasanda, you might know, right? So how I am treating my patient. Isn't it, Lasanda?
Yes, sir. Yes, sir.
Yeah. Because he is with me now in Telipale. Right? So it's a tailor-made management. So every patient we are analyzing in a different way. So patient might have some social issues, economical issues, gender-based violence. Again, those are the case. Those are the problems. So a pregnant mother with problem or without problem, you are trying to talk to the patient, you are trying to identify the problem for a pregnant mother, but you couldn't find anything. So it is an uncomplicated pregnancy. Can we have uncomplicated pregnancy? Yes or no?
Yes, sir. Possible, sir.
Yeah, we can. So it is an uncomplicated pregnancy. So how are we going to manage this uncomplicated pregnancy? What are the things we are going to do with this uncomplicated pregnancy? Sometimes this pregnancy is complicated with GDM. So GDM complicated pregnancy. So how are you going to manage that patient? You got the point. So I'm telling you the most important thing you have to concern during the Viva class. Don't think as a theory. You might be very good in theory. You might have marvelous knowledge. Your English might be very good, but that will not help you to pass. The language or knowledge, it's not enough to pass. Here we need your soft skills, your communication, sympathy, empathy, organization, planning out the management, summarize the stuff, presentation, right? So here try to develop your soft skills. But in MCQ, if you try to study, of course you can pass. Now, if you study that MCQ or theory with me, actually this time you don't need to read the theory again. The knowledge you gain during the MCQ classes is more than enough. Now you concentrate your soft skills. How to communicate, how to take the history, how to summarize, how to organize, how to interpret it, how to analyze, how to combine, how to manage. Right? So more than that, here, in addition to this presentation and all, here you need to handle two people. Who are those two people? One is examiner, another one is patient. One is examiner, another one is patient. Right? So I told you earlier, last time I had around 90 to 95% pass rate. Still, some of my students couldn't do the exam well. But personally, I know them, how good they are. How is their knowledge? When I was when they were telling their results, I was shocked. So no, they failed. But that doesn't mean they didn't study. Their knowledge is poor. They were very good. They tried a lot. They present a lot. So because I was the teacher, I know them. Even 90%, 95% of students, I made them to pass means why I couldn't do that 5%. The same teacher, they were good, but still they couldn't do it because there are several other factors in Viva. But if it is an MCQ, other factors are a bit less. If you do the careless mistake, poor time management might fail you, but even time management also your fault, right? So careless mistakes, yeah, that is your luck. But in Viva, more than your studies, there are other factors might determine your pass. Yeah, can you just tell me what are the other factors might impact on your pass rate? Impression, smile, beauty, color. So when I'm going to the exam, a good morning, sir, then examiner will not like, right? So the dark boy. So if you are a female, then of course you can pass. Is that so?
Previous candidates' performance.
Okay, I agree. Previous candidate performance, yes. Because when the previous candidate perform well, then examiner will be in that level. So when you perform bit of lower, then he will compare, right? It's not a standard assessment. That is the problem here. It's not a standard manner because it's a human being. So you need to understand your threats. So why I'm trying to tell is, if you understand your threats, you can do some practice to overcome these threats. So the previous candidate, yeah, when the previous candidate is doing bad, even if you do average, the examiner might think, so you did very well. Yeah, okay. Previous candidate talk. Anything else? Examiner is moved, right? So if the examiner had problem with the wife, purely it reflect on you, right? Yeah, of course. Some examiners are kind persons, appreciating, right? So they are helping you to present. So when you are presenting, yes, okay. What else you have seen? Good, very good. So then you are motivated. He's motivating you. So then you present very well. So when some examiners are not talkative, whenever you present, they are saying somewhere and they are not concentrating. So you don't know whether you are telling correct, whether whether the examiner is listening. So when I was presenting my part 2 case, one of the examiners seeing the phone. So then I don't know whether he is listening, whether I'm telling correct. So then how to bring the examiner to my attention? So those things I will teach you, right? So the examiners move, the time of the exam. So if you go to the exam in the morning, then examiners are like fresh. Maybe in the evening, they are tired. Your previous candidate made them depressed, right? So they might be tired and they are waiting for the private practice. They are hurried to go to the private practice and all. Oh yeah, of course. The next thing is the patient. Some patients are very, very supportive. They might give the relevant information to you, right? They might give the relevant information to you. Some patients are not supportive. They are just talking unnecessarily. So irrelevant things, right? So some are very angry. Sometimes they are crying. So when you are talking about the suffered lady, then patient is, oh doctor, I can't go like this, and she started to cry. So you need to take the history within that 5 minutes when the patient is crying, how to manage that patient. So it's kind of difficult. And of course, now you are going to handle the woman. So unfortunately, in obs and gynae, always you will get female patient, isn't it? So handling the woman is very difficult. Talking to the patient or woman is very difficult. So you have to ask in a way patient can understand, and patient, you should not disturb the patient mood as well. So the patient factors. So there are so many luck. There are so many factors will play to your pass. You got the point? So Now, how you are going to overcome these issues? How you make this conversation very interesting, interactive, right? So that will help you to pass the exam. So memorizing the stuff, just presenting what you have asked from the patient will not help you to pass the exam. Here what you have to do is you have to properly take the history in an organized manner. So I always telling to my students, right? So you might think what I'm telling, it's not important. Please keep it in your mind. These are the very, very important things, right? Usually it is like that. Most of my students are realizing what I'm telling at the exam, not during the class, right? When you present to the examiner, when you're working as a house officer, that time you will realize what I was teaching is most important thing for your career, right? For your career. Right? Okay. Now, when you take the history and when you present the history, what is the difference? So I will explain you in a detailed manner during the course, but I will simply guide you how we are taking the history and right. Okay. Now, when you take the history, right? So this is the patient. This is your examiner or maybe your consultant, whoever. So you are here, you are taking the history and you want to present. So when you take the history and present, so patient will tell the history in their native language. Right. I forgot to tell one more factor which can affect your pass rate is the language barrier. So Sinhala students who get Jaffna station and the Tamil students who get Sinhala station and they don't know the language, that also might play a role in your pass rate, but usually they help for the translation. Right? They might provide translations. So, but some stations, some examiner might not help on that. So you might have problem in the language as well. Right. Okay. Now, here, when you take the history, you are going to present to the examiner, right? Take the history and present to the examiner. So patient will tell the history in their language. But when you present the history to the examiner or to your consultant in English. So what the most of the students are doing is they are translating the history and present to the examiner, right? So what is history? History is story. What patient is telling is the story. So what the students are telling is they are just going to tell the story what the patient told you to the examiner after translation. Okay, so I can tell you one example. I used to tell this example because I can't forget this example all the time, because one student was presenting a history to me, right? Like a 32-year-old mother of two, or 32 or 38-year-old mother of two presented to the hospital with heavy menstrual bleeding. She had the bleeding since her age of 24 years, and it is affecting her day-to-day life. And she went to DMH hospital, and they have done a scan and some blood test, and it was normal, and they gave some medication, probably tranexamic acid, and she was okay with that for 6 months. Again, she developed bleeding and associated with abdominal pain, and she took the same medication, but it was not responding. And she went to the Castle Hospital again. And there also they have done the scan, and they told a small a small tumor in the uterus, and they said no need of operation, and they gave another drug to drink or take during the menstrual cycle period, and also the other than the menstrual cycle period, probably a nodesterone, and with that it was it responded, and she was okay with that for 3 years, and again now she's having a bleeding, and she took the same treatment, but it's not responding, and she went to a private sector for the consultant. Now she came to the Kalubola hospital for the further management. Now ultrasound scan done, the tumor has increased in size, and it's now 8 centimeter. They said it's fibroid, and they are going to do the surgery. How is the history? How is the history? This was the history was presented. Is it correct? Now, what is the diagnosis? Now, that person can tell, yeah, this is fibroid. She had a small fibroid 3 years ago. Now the fibroid size increased. Now they are planning to do the mammectomy. So what is the surgery? What is the diagnosis? Is fibroid. So what is the management? Mammectomy. So how is the history? What do you think, Sajan? Is it a good history? Yes, right? Because she told each and everything. She or he told each and everything what has happened in her reproductive period and the problem. Faintishness, repeat cast. Now, the problem is, in your clinical assessment, in your exam, what is the expectation? Is to find out the cause by yourself. If the patient say, doctor, I'm having fibroid, then why you want to present to the examiner? Why you want to become a doctor then? If a patient can tell, doctor, I'm having fibroid, then you are treating the patient. So it is almost like a theory, MCQ exam. So do you think patient will come and tell you all the time, doctor, I'm having fibroid? No. What is the significance of telling all these hospital names and going blah, blah things? If you go to DMH, what are the diseases? If you go to Kalgovila, what are the diseases? If you go to Castle, what are the diseases? Those information actually not relevant for us. So as a clinician, what you want to do, now she's having a irregular heavy menstrual bleeding for 6 years duration. Right? So if you present what the patient is telling, then we don't want a medical professional. Even a journalist can do that very well with a good English. What the patient is telling, he is telling the patient is telling in a chronological order, then that person also will tell that after translation in chronological order with a good English. Then why we want medical professionals? So we can use some journalist, yes or no? Journalist can do that rather than a medical professional. So medical professional history can't be like a journalist history. So your history should be kind of analytical history. Now, first of all, when the patient is telling some symptoms, first you need to identify the most important symptom. As I told you, there could be 2 types of symptom. One is the symptom which brought her to the medical care, and second one, the symptom which will help you to identify the disease. So you need to identify the important symptom. Second thing, if you are a medical professional, you can't just present to someone, because patient can tell whatever the shit, because patient don't know whether it's relevant or irrelevant. right? Patient don't know it's relevant or irrelevant. So one day, so I used to tell this story when I was medical student. One patient comes. It's a medicine case. When I was finally a medical student, they have given that patient for the long case. The presenting complaint was coconut fall on head. Amma, why did you come to the hospital? Coconut fall on head. So, could it be a long case? Coconut fall on head. What are the possible differential diagnoses? What are the possible causes for the coconut fall on head? Could it be long case, this one? No, right? So, coconut fall on head is the symptom which brought her to the hospital. But that is not the symptom you need to analyze here. So that's why I'm always telling you there could be two types of symptoms. One is the symptom which can brought her to the hospital, but that will not help you to diagnose the disease. Sometimes the same symptom might brought her to the hospital. So the anemia symptom is the symptom which could be the reason she came to the hospital. But you need to identify which one is the most important symptom which can help you to diagnose the disease. So you can't tell the story what the patient is telling, you can't present to the examiner. Then that is going to be a journalist history. We don't want doctors. We need doctors to present the history after the process. So what are the process? So when the patient is telling symptoms, first you need to identify the main important symptom. Now this patient is having heavy menstrual bleeding. So what kind of heavy bleeding? Whether it's heavy or less, whether it's regular or irregular, whether it's associated with pain or not. So first of all, you need to identify the problem. Regular heavy menstrual bleeding. Irregular heavy menstrual bleeding. That is the first problem. Now you thought she has this problem, but before you analyze that, you need to identify or you need to interpret it. Is it really heavy? Because symptoms are patient's perception. Yes or no? For Sajan, I am fair. But when you ask Rishmi, she might say, no, he is very dark. So what do you think? Am I fair or dark? Yes, Sajan? Yeah, it's depend on the person. Okay, but Sajan might say he is dark. Rishmi might say he is very fair, but I might say no, I'm not. I'm in between. So three people have different three perception. So sometimes Rishmi might say no, he also dark. He is dark, but I'm telling no. I'm very fair. So that is my perception. So when I'm telling I'm fair, your duty to interpret it, is he really fair? There are several ways to assess whether I'm really fair or not. So the first thing is you need to interpret it whether that symptom is correct or not. When a patient say, I'm having heavy bleeding, the first thing you need to analyze whether it's really a heavy bleeding. So the first step is interpretation. Right? Interpretation. So when you interpret the symptom, you know, yeah, this is heavy bleeding. Now, once you interpret it, then you need to analyze why she is having heavy bleeding. What could be the reason? Could it be due to fibroid? Could it be due to malignancy? You are analyzing. So the second process is analysis. Right? You are analyzing what could be the reason. So after analyzing, you know what could be the reason for this heavy bleeding. Now, this patient presented with heavy bleeding due to fibroid. Now you analyzed and found. After analyze, you need to organize, because patient might say in different, jumping here and there. You need to organize in a chronological order, in a nice manner. So then you have to organize your history. You were talking with the patient for 10 minutes, but you are going to present for 1 minute. So you can't present what you had chat with the patient. So then what you want to do, you want to summarize. Then only you can present. So you take the history, translate, interpret, analyze, organize, summarize, then only you are presenting. So the history presentation as a medical professional, you need processing. You can't do like a journalist. So most of the students do journalist history presentation. When you are going with case-based history taking, you are having a format of history for PIH, format of history for GDM, format of history for anemia. You memorized already. You just ask that questions, just translate and present. It's not a processing history. It's a journalist history. So you are not supposed to present the journalist history. So before you present the history, you need to process this history before you present. So our entire course is to aim to teach you how to do this process. How to interpret, how to analyze, how to organize, how to summarize, and finally the presentation. So presentation is the last part. So that's why I told you, if your English is not good, your presenting skill will not be there. Your English is not good, you won't miss or you won't lose much marks, because you have a lot of marks for the other process. Your interpretation, your analysis, your organization, your summary, only you are going to lose your English proficiency. It's very less marks. So if you are good in English, if you are good in presentation, without analyzing, just translate and present the history, nothing will happen. You can't pass the exam. You got the point. So history taking examination is an art. You need practice. It's different from your MCQs. So slowly we will develop. So at the end of this course, you can simply pass the exam. The way you are communicating, way you are talking, way you are analyzing, way you are interpreting, way you are summarizing, way you are presenting, the examiners know you trained well. What is the examiner's expectation? What the examiner is expecting from you? Anyone? What is the examiners are expecting from you? Anyone?
Safe house officer.
Yeah, that's it. Is he or she a safe house officer? Can I keep her as my house officer? Can I believe her? Is it okay to keep her in the ward? Will she kill the patient? So you need to show to the examiner you are a safe person. You are not missing the important thing. You are analyzing in the proper way. Do you understand? So they are not analyzing your knowledge, because just imagine, plan out the management, plan out the high-fi investigation is the duty of consultant. Performing cesarean section, step of cesarean section is the duty of senior house officer or consultant, not the house officers. But prepare the patient for cesarean section. Whose duty? House officers. So what the examiner will ask from you is, as a house officer, how will you prepare this patient? As a house officer, how will you manage this patient? So when they're asking, okay, you are the house officer, how are you going to manage? Then don't tell, I will prepare the patient for the cesarean section and I'll do the internal iliac artery ligation. If bleeding is going, then I will do the hysterectomy. That is not the house officer's duty. The house officer's duty is, I'll put 2 white-bow cannula, preserve 4 pints of blood. I'll explain to the patient, if the bleeding is persisting, we may have to go for a hysterectomy. That is the house officer's duty. So when you are answering in the exam, you should know what you have to tell to the examiner. What you should not, you don't need to tell to the examiner. Sometimes so you need to tell to the examiner, if the bleeding is heavy, we may have to do the hysterectomy. But don't tell, so if the bleeding is not settled, I'll do the hysterectomy. So then examiner will ask, is it your duty? Can you decide to go for a hysterectomy? No. But you can tell to the examiner in a way, I know that stuff. How? Sir, as the bleeding is heavy, I'll prepare her for the laparotomy for the surgical management, and also I will explain to the patient and get the consent for hysterectomy in case of bleeding not settled with the other measures. Now, what you have shown to the examiner, you know the stuff. If bleeding is not settled, we may have to do the hysterectomy, and you shown to the examiner what is your duty in this patient. You got the point? So this is how we need to prepare, how to answer, how to handle the examiner. Just imagine if you answer like this, then definitely examiner will impress on you. Yeah, he's a nice person. He knows the basic stuff. If I keep Sajan as my house officer, so I don't need, because when I'm getting called, so while I'm doing the class, I might get a call, sir, there is a bleeding, please come. So I might land it to the theater straight away. That time patient might be on anesthesia. So straight away I might do the hysterectomy. So I don't have chance to talk to the patient to do the hysterectomy, get the consent. So before I come, who is going to do that? His house officer. So you should know what is your duty, what are the things you need to know, what are the things you have to follow. Right? So in the exam, you need to tell those things in the exam. So the way of answering will carry you more marks. So that's why I'm telling, you don't need to recall entire sophisticated theory things. Even if you forget like fetal fibronectin level, they will not fail you. But if you forget to tell, sir, I will give dexamethasone, then they will fail you. Because fetal fibronectin decision is by the consultant. But if you suspect preterm labor, what is the first step of management? Tocolytics and the dexamethasone. If we give dexamethasone early, that would be better for the patient. If you are delaying the dexamethasone by not knowing we need to give dexamethasone for a patient and waiting for the consultant, that is the dangerous part. You got the point? Even if you forgot the hysterectomy for the obstetric hysterectomy for the PPH, they will not fail you. But if you forget to send a 4-point DT or 2 white-bow cannula, that is dangerous. So there are certain things must know. There are certain things nice to know. So nice to know things will not fail you, but must know things will fail you. Right? Whether you took very good history, whether you took your examination, whether you present very well, but certain very important things, if you forget, then simply they might fail you and give the explanation. He is not a safe house officer. So one of my seniors, she failed in medicine exam. She got distinction marks, but she failed in the medicine exam. She missed the pale. Because simply the examiner told she missed the pail that can kill the patient. That is the house officer's duty to detect the pail. If she can't detect the pail, how I can rely on her? She might kill the patient. So they failed. But next time she got through and now she's consultant physician. Because intelligent, it's not going to help you in the exam alone. Right? So your presentation, your way of answering, right? You can't miss something. So the must thing you need to know. In my part 2 exam, there were candidates failed. My friends, my colleagues failed in the exam. You know, there are a few things. One, they fail because they don't know how to measure the blood pressure. They were asking, can you just tell me the steps of blood pressure monitoring in a pregnant mother? The steps was wrong, and the examiner who came from UK, he failed. All the candidates who failed to answer how to measure the blood pressure. Then the local examiner were arguing with the foreigner, why you are failing a person, a consultant, because once they go through the part 2 exam, they are going to be the consultant. Why you are failing a consultant? Because he don't know the steps of blood pressure. Because anyhow, in clinical practice, who is going to measure the blood pressure? Consultant or house officer? Who is going to measure? House officer. So in practical life, the consultant is usually very rarely measuring the blood pressure. So actually, I don't have stethoscope. As an obstetrician, my weapon is this. I don't want stethoscope. I rarely use it. Very, very rarely I'm using stethoscope. Because most of the things will be done by the house officers. So then why are you failing those candidates? The explanation was given by the examiner is, if he's going to become a consultant, he's going to be the teacher to the house officers and the other staff. If a teacher, a leader don't know what is the correct step, how can we let him to be a leader? And they failed. So just imagine the reason for failing. But in SBA, if you got more than 45, you pass. That's it. Right? Whether you did the mistakes in basics or whether you did the mistakes in fundamental, never mind. If you got 45, you pass. But in Viva, it's an individual assessment. They look at you in every aspect. They can decide whether we can pass this candidate or not. You got the point. So the information which I have given today, those are very, very important to you. Now, at least you might know how difficult this Viva. But if you know this basic stuff, now when you come to the Viva class, you will understand. I'm going to teach you the basic, not the sophisticated thing. But when you come to the theory class, you realized it, right? So I was teaching very sophisticated things also from the pathophysiological basis, because these days the exam is targeting this pathophysiology and sophisticated things. But when you come to the Viva, I will teach you in a different way. The things you must know as a house officer. Okay, right. So I think we can meet in 27th. So actually, I plan to do 1.5 hours with that patients handling one, but unfortunately, we couldn't bring him because of the power cut. So I will contact him and I'll try to do the free class. If you have any questions, we can discuss. If not, I think we can stop with that, right? Yeah, any questions? Any clarifications? When will you give the iPad app? Yeah, it's in process. But you can access the classes, even if you miss the class, you can access the classes through the Maura Education 24/7. So that is the benefit to you. Any question? If not, we can stop. Class via Zoom link. Yes, of course. Zoom link, but the Zoom link will appear in the Maura Education. So anyhow, I'm having the backup plan. So I'm giving the direct Zoom link, and also please activate your Maura Education. Planning to do the classes through the Maura Education, but that is incorporated through the Zoom. So the Zoom data and Zoom app will be utilized through the Maura, right? So last time we tried, but there were some technical issues. So we are fixing now. So we will try to do the Maura through Zoom. If we have any issue, then straight away we'll go through the direct link which we have sent. I already have sent that link to you. So whenever you are sending your payment slip, the coordinator will send you the link, as well as he will ask you to activate the Maura Education app. So please activate your Maura Education app. So if you are a previous student, if you have OGR number, so you can activate your previous account, because already your previous attended courses are enrolled there. So then you don't need to pay again. You can access the classes through that. But if you are a fresh student, first time if you are attending to my classes, you can create a profile, and you will be enrolled into the platform. So then you will get the access through the platform for 24/7 restreaming access. So if you miss the live case of classes, you can access the classes. So the small group discussion will not be uploaded, okay? Because the purpose of doing the case discussion is to present by yourself. So no point in uploading those small group discussions. So I'm expecting you to present, right? And a lot of people were asking the SBA, but I don't give, because last time also I didn't, because I don't like to spoil your free time now, right? So this is the good time. In 2 weeks time, you will get the answers of results. No, now you can enjoy your free time, right? So a few more suggestions. This is my personal option. So shall we initiate with the tummy before we do the exam real patient handling? You don't need to worry, because my way of teaching is that when one group comes for the examination classes, I will teach you the correct technique on patient, right? So then I will ask the students to do the examination, and I will correct it. That is how I do, isn't it, Lasandar? That is how we do, right? So then rather than doing the dummies, so better to do with the patient. That is, until it is possible, we can do that, okay? But yeah, if you want more practice, we can arrange that. But better if you touch the patient. That would be a better option for you, right? At least do one examination in front of me, then I will correct you. So when you are doing the examination, when you come to the clinicals, then you will realize it. So how extent I am correcting, right? So very small technique I use to correct it.
Patient exposure.
Yeah.
Patient exposure better, sir. Right?
Yeah. Patient
Patient
exposure.
exposure better, right, sir?
Yeah, better. Yeah. Because when they are coming first time, so they are freshers, Lasanda. So then they need some experience, right? So when they are coming, then they will realize which one is better, right? Yeah.
I got it.
Yeah. Right. So shall we meet on? Yes, Sanjeevan. Hello. Sir, can we call now regarding the free sessions? Yeah, of course. No problem. Okay, so then we will meet coming Thursday evening 5 p.m. With Viva session 1, and the students who are coming clinicals group 1, we will meet on Thursday morning, 27th morning, right? So roughly 15 to 20 students will be allowed for the first case. Okay, bye.
Thank you, sir.
Yeah.